All right, we're going to go into part 2. Talk about the placenta, the maternal cervix, biophysical profiles, and then some twins. So the placenta is a fetal organ. It's a support organ. The lay term is after birth. The placenta size reflects fetal size and health. It's a transfer site for oxygen, carbon dioxide, nutrients, and it synthesizes hormones and prostaglandins. The attachment to the uterine wall is what we're looking for, so it can be anterior, posterior fundal, left lateral, right lateral, previa, or variance. So when you're assessing that placenta, make sure you scan in both planes, both sagittally and transversely, because you can have an anterior or posterior placenta that wraps left lateral, wraps fundal. So you want to make sure that you evaluate it in both planes. The complete previa can be central or partial. It's when it is covering the cervix, then it's a complete previa. Marginal comes to the edge of the placenta, edge comes to the cervix, but part of that membrane can cover the internal os. Low line is within 2 centimeters of the internal os. So we want to assess the placental thickness. The placental thickness increases with gestational age all the way up to about 4 centimeters. Placentamegaly is if it's usually 5 centimeters or more, then we call it placentamegaly. So remember, when you're measuring the placenta, but you're not including the myometrium. So this is uterine wall here, and then this is placenta. So that's what you're measuring, is this, again, perpendicular to the placenta. You want to measure the thickness. So your babies that get hydropic, sometimes your babies with triploidy, other aneuploidies, you'll see that the placenta is a little thicker. A placenta that's not working well sometimes will be thick. So I mean, just looking at this, you can see here's myometrium here, but look how thick that placenta is. And this baby had decreased fluid and IUGR. So a lot of times it's going to reflect, it's the first thing that's showing us that this baby's at risk. So it reminds me of like in Minnesota sometimes. You know, we have thinner branches and then you have big, thick, fluffy branches. So how thick is that placenta? If it's greater than the 90th percentile, the placenta size greater than the 90th percentile, can be seen in small and large for gestational age fetus, and it has increased risk for the perinatal mortality. So that's why we're looking at this. It's helping us to assess how often do I need to scan or look at this mom? Does she need to have testing with biophysical profiles and evaluation in the 3rd trimester? So we look at the placental grading. When it's homogeneous, no calcifications, nice smooth chorionic plate. Basal plate is towards the myometrium, chorionic plate is towards the fetus. This is your typical appearance of the placenta prior to 24 weeks. We can see there's umbilical cord coming in here. It's a central insertion. In a grade 1, you're going to have little echoes randomly dispersed throughout the placenta. You can have small, little subtle indentations along the chorionic plate. And this is your typical appearance for 24 to 30 weeks. Your grade 2 has these echogenicities along the basal plate also. You have like these comma-like indentations along the chorionic plate. And you can see them going sometimes from the chorionic plate to the basal plate, not quite connecting yet. This is your typical appearance from 30 to 38 weeks. And then your grade 2, you can have these indentations along the chorionic plate. And then the grade 3, now you can see how they're almost from the chorionic plate all the way to the basal plate. You have more of these calcifications. You have irregular densities, some acoustic shadowing from them, a lot more indentations, the cotyledons along the chorionic plate, and this is your typical appearance after 38 weeks. Now, the one time that you'll see these earlier in the pregnancy is your smokers, your moms that are smoking a lot, some of your drug abuse cases, anything that's maturing that placenta. And then you worry about, you know, the baby, the placenta runs out, it cannot support that baby anymore. So they're at increased risk for 3rd trimester complications. So remember, placental grading based on the echogenicity attributed to the increased calcium and fibrous depositions within the increasing placenta age. At term, 45% of your placentas are still a grade 1 at term. 55 are a grade 2, and only 5 to 10% are going to get to that grade 3. So we used to think that, if we could look at the placental grading that we could tell lung maturity, and that's not true. That never panned out. So it's a little clinical value. I mean, we usually look at it to help predict which women we need to test more often. Your chronic hypertensive, people who are at risk for preeclampsia, your babies that are small, and then your smokers. So some of these sonolucencies with placental lakes within the placenta, you have your umbilical arteries carrying the blood from the baby through the cord back to the placenta, and the maternal blood coming in along the basal plate. All the interconnections here in the middle of the placenta, and then the umbilical vein carrying that oxygenated blood back to the baby. So placental lakes are just in large intervillous vascular spaces, greater than 1 centimeter in diameter, and when you magnify up on them, you can just turn up your gain and you'll see that it looks like the blood is just swirling in there. It's most often considered a normal finding or a variant of normal. More concerning if you see it early in gestation, less than 20 weeks. You can sometimes see more of these with your babies that are growth delayed, and sometimes you can see them with oligohydramnios. But the good rule of thumb is, we used to measure these, document them, follow them up every 3 weeks, and guess what? Most of the time the babies do fine. So if there's normal growth and normal fluid, we don't really pay a lot of attention to them anymore, unless they're huge and occupying a vast majority of the space of the placenta. Greater concern, again, if you have a small baby or abnormal Dopplers. You can talk about placental hemorrhage, depending upon the location, whether it's retroplacental, whether it's intravillous, if it's at the margin, if it's subamniotic or subchorionic. Most of the stuff that we're going to see is going to be subchorionic. And remember, wherever the bleeding was from the placenta, it's always going to go to the area of least resistance, which is usually at the edges or the margins of the placenta. So you can see a lot of these hemorrhages, if it's a fresh bleed, it kind of blends right in with the echogenicity of what the placenta is. As it's like any clot. When it forms a clot, then it starts to change. Then it looks septated, and then it looks cystic. So depending upon the stage of the clot, it can look different, have different appearances on ultrasound. Some of the pitfalls and variants that we see when we're trying to assess the placenta, looks like we've got placenta here and placenta there. But you watch it over time, and what was it? Focal myomutual contraction. So that's why we try to stay away from that rapid hydration of moms too, because it makes those uterus very irritable, and you tend to get more of those little practice contractions. Look for the placental cord insertion. Again, not mandatory yet, but recommended. It can be normal, marginal, or eccentric, velamentous. So we'll go through each of these. So looking at the posterior placenta here, this is a nice central insertion into the placenta. We can see the placenta mass towards the back or posterior. Eccentric just means that it's not in the center. Marginal is when it's within 2 centimeters at the edge of the placenta. And then velamentous is when it's into the membranes, and the vessels are a little bit more vulnerable because they're traveling through the membranes over to the placenta. This is what the fetal surface of the placenta looks like. This is thanks to some of the docs that I work with. They give me these images to look at. But here's your baby's cephalic. So I'm writing on the machine how the baby's laying, cephalic. It was an anterior placenta. I'm documenting where the placenta was, and then this is the cord insertion into the placenta. Here's another one. So again, just documenting, with the color, it really helps to identify where that cord is coming in. So marginal insertion of umbilical cord is within 2 centimeters of the placental edge. So we see the majority of the placenta is towards the back wall here. Look where that cord's coming in. So then I measure how far. If that insertion is within 2 centimeters of the edge of the placenta, we call that a marginal cord insert. Velamentous cord insert is when the cord insertion is into the membranes. And it's really a result of trophoblastic trophotropism, which is wherever the placenta implants, that's where the cord is at. So the cord is telling you where the initial implantation was. If there's not good blood supply there, the chorionic villi don't continue to grow there. They start to atrophy, and it starts to grow wherever there's the better blood supply. Well, the cord can't move. So then you have the cord stuck in the place where original implantation was, but now the placenta is way over here. So now you have vessels that are traveling through the membranes over to where the placenta is at. So it can be associated with lower birth weight, fetal growth restriction, preterm delivery, low APGAR scores, thrombosis, and then vasoprevia. Now, we see more of these in association with our monochorionic twins. So when you have monochorionic twins, really start looking for abnormal insertion sites into the placenta. So we can see the cord insert here traveling through the membranes and then over to the placenta. This is what it looks like on an ultrasound. So we're looking sagittally. This is up into the fundus of the uterus. Placenta is here. It was anterior placenta. Look at where the cord comes in here. It'll be straight, and then you'll see those vessels traveling along the wall in the membranes over to the placenta. This is one of those, I mean, if it's up in the fundus, most of the time it's not going to be a big deal, but what if this is down in the area of the cervix? Now you have these vessels over the cervix. So if you're just documenting the placenta and not looking for the cord inserts, you're going to miss these. Just with the grayscale, it was kind of hard trying to see where that cord was coming in, but here it looks like it's coming right along this right lateral wall. So again, throw the color on, and there we can see it. So we have the insertion into the membranes and then the vessels traveling over towards the rest of the placenta. Some of the variants we see with the placenta are a sexcenteriate lobe or accessory lobe, circumvallate, and bilobate. So 3 to 6% of pregnancies will have a sexcenteriate lobe. Majority of them we don't even pick up. They're small, we don't even see them. You see them when you deliver. You must distinguish it between a bilobate placenta. So you have your main placenta, and then you have the cord inserting into that placenta, and then you have these little vessels that go to this little accessory lobe. Because in the beginning, remember when you have early implantation, you have chorionic villi all around that little blastocyst. Where the implantation occurs, that's where your cord is, and the placenta, the chorionic villi start to proliferate. The rest should atrophy. Well, sometimes there's some that say, well, I don't want to atrophy. I'm going to have my own little thing. And then you have these vessels connecting. And again, if it's over to the side, it's not a big deal, but sometimes you can have an anterior placenta, posterior sexcenterior lobe, and you've got these vessels right across the cervix. So again, looking for these things, just being aware, and if it doesn't look completely normal to you, send it. So here's the anterior placenta, and there was that right lateral posterior little sexcenteriate lobe. So key with these sexcenteriate lobes versus contractions, watch over time. If it's a contraction, they're gonna go away. A contraction can mimic a fibroid, it can mimic a placenta previa, it can mimic an accessory lobe of the placenta, so just watch it over time. Because this was just a contraction. This was just a contraction. A circumvallate placenta, it only affects about 1 to 2% of the pregnancies. It's just a rolled rim of placenta tissue at the peripheral edge of the placenta. So it's a mismatch between the amnion and the chorion. So the membranes actually are inserted into the fetal surface of the placenta. So you can see like this little rim of tissue all the way around here. So most of the time it's just one area of the placenta that's affected, unless it involves more than 60% of the placenta. It usually is not a problem. The circumvallate placenta, though, is the one that can be confused with the uterine synechia. So you want to make sure you look at this, because a marginal shelf with a circumvallate placenta looks like a uterine synechia, but it's attached placenta to placenta. So that's a rolled edge of the placenta, and then when you turn on it 90 degrees, you can see where it's attached. So it's a marginal shelf associated with a circumvallate placenta, not a uterine synechia. So it's just this little mismatch here. But it's attached placenta to placenta, where uterine synechia can be, it's uterus to uterus, it's scar tissue, and then you can have part of the placenta over there, but one end is just going to, it's not attached to the placenta, it's attached to the uterus. This one was the uterine synechia. Look, placenta's here, but this goes to the uterus. And she had had some previous procedures done. So that's the difference. So a lot of times you look at these and you're like, okay, where is it attached? That's what you need to know. Now with a true bilobate placenta, you have two placental masses that are fairly equal in size, and the cord insertion is into the middle, this little membrane between the two lobes. You have increased risk of cord accidents, And you just need to make sure, just with the accessory lobes, bilobate placenta, just make sure it's documented so when they deliver the placenta, they make sure they get all the parts out. Otherwise, they're going back for a retained placenta later. So yeah, that bilobate placenta, anterior and posterior, little membrane over here. Then she had some bleeding. Look how you can see elevation here of that space where there was some bleeding behind the placenta, and put color on, and there's that cord insertion right in between those two lobes. See that? So again, that color will help you when you're trying to figure out where is this cord. And if you don't have color on your machine, just turn up your overall gain. You'll see the blood flowing. You'll see the movement. Go over to the maternal cervix evaluation. Again, use your amniotic fluid. You don't need a full bladder. You can use the amniotic fluid. Come up a little bit higher and angle back down so that you can see the cervical length. If you are having any problem seeing the cervix at all, or if there's been prior procedures to the cervix, then you really are obligated to do the transvaginal. Pitfalls is you can have artifact from the bladder. If it's just for a little bit, you get some shadowing from the interface between the cervix and the bladder wall, and then shadowing from the fetal head. Some other pitfalls is here, there's head here, and the cervix looks closed. Baby moves the head out of the way. Look, that's open. These are membranes down through the cervix into the vagina. And this full bladder did not help us. So you can see how much fuller it was here. We had her go empty her bladder. She still had fluid in there when she came back, but look now. So you can falsely compress that anterior wall together, making it look like a preview, or you can compress the cervix down, making it look like the cervix is closed when it's not. So do yourself a favor, don't fill the bladder up anymore. So the endovaginal approach, we're looking from the maternal feet, so we're in the vagina, and when you're scanning, make sure that you are active real time as you're inserting the probe. And if there's any history or a questionable history of ruptured membranes, do not do a transvaginal scan. You can do a transperineal. There's other ways to look at it. But if you think there might be fluid coming out, the last thing you want to do is put that transvag probe in there. So we're coming in, we're going to look right at this area here, so trying to evaluate the length of the cervix here. You see a little bit of debris here. So this one was being sent in for threatened, what they thought was a small or shortened cervix on an outside scan. So we're looking here right in the vag cuff. So this is actually the cervix. There's the endocervical canal. This one has a little bit of beaking. This one's a V shape. So we used to measure the total length, the shortened length, and try to overall estimate of the length. Now, really what you're interested in is what is the residual cervical length? What is the closed cervical length? And you don't go all the way back here to the vag cuff. It's this area right here. That's what you're measuring. So I think the most common mistake that I see when I'm scanning with people is that they're inserting the probe too far. If you watch while you're scanning, and you really don't have to insert the probe that far. This is a U-shape funneling. Again, looking at that residual. And anytime you see a little debris down here, that's another indicator that, this is a true cervical incompetence, and they are at high risk for preterm delivery. This is just a video clip showing how we measure that. Do not include this vag cuff. 1.4 millimeters. Pretty short. This is transperineal. So you just take your 6 megahertz transducer that you do your surveys with, put a glove on it, gel inside, and then gel on the outside, sterile gel on the outside. Just spread the labia and just put the probe right there, and this is the view you can get. So we're just coming here and we're looking. It takes a while to get used to scanning that way, but you get a fairly close image as to what you get with a transvag. Okay, so evaluation of the relationship of the placenta to the cervix, you assess for previa. You want to measure the distance of the inferior placental margin from the internal cervical os, and then assess for umbilical cord insertion site. Make sure that it's not near that cervix. So as you read different books and different articles, they'll call it marginal, partial, complete. The main thing is it covering the cervix, and then how far away is the placenta from the internal os. So abdominally, it's about 90-95% accurate in experienced hands. transvaginally 99% accurate. So if you're suspecting a previa, you really should be doing a transvaginal evaluation. So placenta previa is painless vaginal bleeding. Complete previa completely covers the internal cervical os. It can be central or partial, so just a margin, a part of the placenta covering the cervix. With the central, you have the mid portion of the placenta over the internal os and more than 1.5 centimeters of the placenta over the cervical os. It wraps anteriorly and posteriorly or right to left. It's right over the middle of that cervix, and that's rarely going to move away from the cervix. It has a greater likelihood of bleeding and hemorrhage in the third trimester, so you want to go ahead and assess them. This is the central previa. So looking at the bladder, looking at vagina, this is cervix, there's the placenta. Even transabdominally, you can see that one. So marginal or partial, you have part of the placenta at or near the internal cervical os, within 2 centimeters of the internal os, greater chance of bleeding. Said to migrate or move, but it's actually just, again, that trophotropism. If there's not good blood supply down there, then the chorionic villi don't continue to grow, but you can have some membranes over there. And where there is good blood supply, chorionic villi will continue to grow. Poor blood supply, nutrition, chorionic villi will atrophy or regress. So it's not like the placenta is getting up and moving away. It's just the physics of it. So you measure the distance, again, of the placenta from the cervical os. So here's the cervix, and the placenta is coming right to that internal os there. Causes some of the false positive is overfilling of that bladder. So cervix is actually down here. This is the anterior and the posterior uterine walls contracted up. So the uterine contraction, fibroids low in the uterus, can mimic a previa. These are all problems from the overfilling of the bladder. Again, the FMC, focal myometrial contraction, artifact from the head makes it look like everything's open. Vasoprevia is about 1 in 2,500 births. Vaginal bleeding occurs upon rupture of membranes. You have fetal heart abnormalities. You have to have the C-section because you can have a baby that dies 22% of the time if this is undiagnosed. This is the one we worry about. So if you have a low line or a partial marginal previa in the second trimester and it moves out of the way, please, please, please put color on over that cervix. Make sure there's no vessels still sitting over that cervix. You can make a huge difference in this woman's care and the baby's outcome. So vasoprevia, the risk factors are low-lying placentas, the bilobed, multi-lobe, succenturiate lobe placentas, because of all these connections from the main lobe over to the other lobe, the velamentous cord insertions, multiple pregnancies, a much higher risk for having abnormal cord inserts. So make sure that you do look at that. And here's that article going over that. So vasoprevia can be seen in association with accessory placental lobes. If the cord insertion is not evaluated, this can be missed, can be life-threatening to both the mom and the fetus. Recheck it at 28 weeks if it was diagnosed as a previa. We don't check them every week. We just have them come back at 28 weeks, unless, their clinical symptoms change. If they start bleeding, then we'll reassess. But usually we just bring them back at 28 weeks and then 32 weeks, just to look to see how close that placenta is to the cervix and if there's any vessels down there near the cervix. And if in doubt, make sure you go ahead and look transvaginally. In our department in Houston, they do a transvaginal just to make sure there's no vessels down there. And this is a lady who had just a low-lying placenta. She came back for her, let's make sure that the placenta's out of the way. Well, the placenta's out of the way, but look, here's her endocervix. And look at these vessels crossing there. Right, so if the cervix appears shortened or cannot determine the relationship to the cervix, of the placenta to the cervix by transabdominal, assess transvaginally or transperineal. This gets easier the more you do them. If suspected premature rupture of membranes, please do not do the transvaginal scan. If you want to do a fetal fibronectin, do not do the transvag. Get all that done first. Watch over time. And then we also do this fundal pressure. Is everybody doing the little fundal pressure, the little check of the cervix to see how it's doing? Because, the patients are sitting, usually they're sitting up. Well, we lay them down, we'll take some of the pressure off the cervix. So sometimes, everything looks fine. You put a little, you're trying to reintroduce some pressure, some gravity to that. So we just have the mom push onto the top of the uterus, just gentle pressure. And sometimes you'll see with a dynamic cervix, it'll just open right up. So we do watch for 2 minutes. We apply some pressure. Watch for 2 minutes, scanning back and forth to make sure that there's no change in that cervical length. Because we'll document without pressure, then we put pressure and we just write up their pressure, and then we scan and we watch. So your dynamic cervix, it looks like it's closed because there's no pressure, and pressure, and it just opens right up. And then you're waiting and getting the shortest length. You're measuring the residual length. Okay, placental abruption causes hypoxia and can lead to fetal death. If less than 30% of the placenta is involved, these areas can heal and the baby does well. So this is when you have the painful vaginal bleeding. And this usually is not an ultrasound thing that we're looking for. This is going to the labor and delivery, and you'll manage it there. Sometimes with a posterior contraction, you can actually get something that looks like a placental abruption, but it was a false positive. It's just a big contraction there. Those little contractions, boy, they just really mimic a lot of different things. Right, we'll move on to the biophysical profile. This is an assessment to help determine your fetal well-being. Fetal profile is an ultrasound-based method to try to test for fetal hypoxia. Really what we're trying to do is try to do an intrauterine APGAR score. So we're looking at movement, tone, amniotic fluid, and then the practice breathing movements. How is that baby doing in there? Is it okay to leave that child in there for a little bit longer? So we're looking at the fetal heart rate pattern. We're going to look at reduction or deficiency of the oxygen supply. We're trying to assess for hypoxia. Periodicity, we're looking at the definition of that as a recurrence at regular intervals of time. So a normal fetus will perform most of the variables of the biophysical profile exam in a 20 to 40 minute time frame. So we usually give them 30 minutes. The absence of one or more BPP variables may reflect normal periodicity, because the earlier they are in the gestational age, the less likely they are to do some of the practice breathing or have the heart reactivity on the NST strip. CNS is unable to perform that function due to an anomaly, so if you have a head anomaly, they may not be able to do some of those components of the BPP, and then hypoxia. So we use 5 components to try to assess how the baby is doing. We're looking at movement, tone, breathing, and AFI and NST. So the first report was by Manning, Platt, and Sipos. Scored 0 when it was abnormal and 2 when it's normal. I know there's some other charts out there where they use a 1. We don't use that scoring system. So it's a combination of acute and chronic markers. Usually start this testing at 32 weeks, unless, in a high-risk population, sometimes we'll start them as early as 28 weeks, but we're not doing the NST, we're just doing the ultrasound components, the 4 components. So what are we looking at? So we're looking at biophysical activity functions initiated and controlled by the different CNS, fetal CNS centers. Fetal tone develops at about 7.5 to 8.5 weeks. So tone is the first to come. Then movement is developed by about 9 weeks, those little bopping movements that we see them doing in the first trimester. Fetal breathing develops after 21 weeks, but very irregular in the beginning, becomes more evident as you get closer to delivery. And then the heart rate reactivity, and that develops by the end of the second trimester. So we're looking at each of these components. So observations to remember is that acute markers are compromised by fetal acidemia. The biophysical activity function that appears first in fetal life are the last to disappear. So one of the last things we see are the fetal breathing and the heart reactivity. Those are the last to come, but they should be the first things to disappear. So the way they come, then they disappear the other way. So the chronic markers that we look at is their placenta appearance, the amniotic fluid. Chronic markers are not altered by acute acid-base changes. That's a result of chronic fetal distress or fetal hypoxia of long duration. Indications for performing the BPP, the maternal conditions would be pre-gestational diabetes, hypertension, lupus, chronic renal disease, antiphospholipid syndrome, hyperthyroidism, poorly controlled, and then sickle cell thalassemias, and cyanotic heart disease. These are the maternal conditions that we're using. Indications for performing BPP that are pregnancy-related conditions would be gestational hypertension, so PIH, preeclampsia, decreased fetal movement, poorly controlled gestational diabetes, decreased or oligohydramnios, fetal growth restriction, late-term or post-term pregnancy, isoimmunization, previous fetal demise, whether it's unexplained or current risk, and then your monochorionic twins. So what are some of the causes of hypoxia? The chronic substance abuse, prolonged labor, placental abruption, premature rupture of membranes. So the guidelines that we're following, the four components are done with ultrasound, and then the last one with the NST, the non-stress test. Your observation time for the ultrasound is 30 minutes, and then the non-stress is 30 minutes. So an abnormal BPP cannot be given if you haven't looked the full 30 minutes. If the baby does everything in 10 minutes, you're done. But if they're not doing it, you have to give them the full 30 minutes. So what do we need to document? Fetal presentation, the placenta position, the heart rate, the AFI, and then your BPP components, which is looking at movement, tone, and the practice breathing. Again, fetal presentation is the most important step because everything else, everything we do, how we scan, how we turn that transducer, all relies on how that baby is laying within the maternal pelvis. Doing that heart mode again, displaying it over time. Again, use the M mode unless you can't get it because of position or maternal size. And in the third trimester, sometimes it's hard to get it. Then you can go ahead and use the Doppler. Again, your normal heart rates and looking at your BPP components. So fetal movement, you need to have 3 or more discrete body or limb movements. It's movement of the body and limb at the same time qualifies as a single movement. A body roll, head rolls, spine flexions, arching their back, flexion extension. And this is just real time. So baby's moving the arm, moving the head, moving the arms again. So you need to at least see 3 of those. Fetal tone, 1 or more episodes of extension of a fetal extremity. So from flexion to extension, back to flexion. You want to see those movements. Arms, legs, sometimes the practice sucking movements. So extension of the spine from extension back to flexion, close and opening of the hands, foot, limbs, sucking, swallowing. And then this does get pretty hard when you're evaluating with low amniotic fluid or multiples. So sometimes what we do is actually, you get your AFI, because that has to be done with mom laying flat on her back, doing the 4 quadrants, and then roll her to her side one way or the other. And sometimes you can get the babies to move a little bit more when you roll them or have them sit up a little bit more. But first you need to document your fluid. That needs to be with the mom on her back. Remember, when we're doing multiples, that you're not doing an AFI, you're doing a deepest vertical pocket at each of their areas. And there goes the foot, and that arm was moving, the arm coming back in here. So a lot of times they're doing the tone and the movements at the same time, and then you can count them. But I mean, you need to see at least 3 movements, and then the tone, you need to see at least 1 of those. Little kicks moving around. Okay, and the fetal breathing movements. At least 1 or more episode of fetal breathing lasting 30 seconds or more. That's the key. And you go, oh, I saw breathing. It has to be sustained for 30 seconds. Some authors use hiccups and count that for their breathing movements. We don't use that in our lab. So you have to decide within your lab, are you going to use it, not use it? We don't use it. So you have to decide for yourself, but this is the breathing movements. So again, that coronal view from the chest to the abdomen, looking at that diaphragm, and you can see that diaphragm moving up and down. These are hiccups. So see how there's a difference? And a lot of times mom will tell you, oh, baby's doing hiccups. I mean, they can feel them. All right, and then the amniotic fluid. So fetal urination, again, begins the first trimester. By 16 weeks, at 80% from the kidneys, and then where it's coming from again, from the skin, the urine, the placenta, the GI tract. So the AFI, make sure you use the color or turn up your gain. Make sure no cord is in your fluid pockets, and standardize it within your labs. Multiple gestations, twin, triplets, and above. Don't do an AFI. You're doing the deepest vertical pocket, which is also known as a single vertical pocket or a maximum vertical pocket, whichever initials you want to use. Just make sure you're standard within your lab. That change in that amniotic fluid is usually the first sign that the pregnancy is at risk for complications. So really pay attention to it and make sure that you're getting good measurements. Normal range, again, is, for deepest vertical pocket is going to be greater than 2, but less than 8. Very important. With your twins and triplets, if you're having a hard time seeing that membrane, you really need to look for that membrane. Turn on one of those color filters. That blue one really looks nice, and turn up your overall gain a little bit so you can see the membranes. Because sometimes when you have these babies that are monochorionic, the one has lower fluid, so some of the other bigger baby's fluid is actually on top of it, and I see people measuring that baby's fluid for the smaller baby when it's not that baby's fluid. So really identify that membrane so you can see where the fluid is at. So amniotic fluid, again, less than a 2x2 pocket. Again, gestational age dependent. And remember, for both the BBP and the fetal Dopplers are valuable tools for the evaluation of fetal health. Must know the grading criteria for each component. Everyone within the department must follow the same guidelines. If the fetus scores 8 out of 8, ultrasound time can be shorter than the 30 minutes, but you cannot shorten the time if all the components have not been seen. Okay, and the last component is the non-stress test, and you're looking for the heart reactivity. And that is 2 or more fetal heart rate accelerations of at least 15 beats per minute for at least 15 seconds in duration. Again, 30 to 40 minute time. So, if they get a baby who's non-reactive, sometimes they say, well, I'll just leave them on for another couple minutes. But I mean, that's, for the physician to decide. But the BBP is just looking at all of these components, the last one with the non-stress test. So how do we score this on the ultrasound parameters alone? Add all the components. 8 is normal. 6 is equivocal. Repeat your BPP in 12 to 24 hours or get an NST. 4, 2, and 0 are all abnormal, so they require prolonged monitoring or further assessment. So you send them up to the assessment center and let them see how the baby does over a longer period of time, because you don't want to send them home and then have something happen. So now there is a modified BPP out there, which is just the NST and AFI only. So now this is one we actually have our nurses doing that. We've trained them how to do the AFIs, and they're very good at doing them now. So it constitutes a reactive NST and a normal AFI level. So all ultrasound biophysical components may be seen by 21 weeks. Of course, the fetal breathing is going to be, maybe you see it once or not at all during the whole time that you're looking. The increase in frequency with gestational age. Some labs use the protocol where they have the patient, make sure the patient eats an hour before they come, to make sure that we've got some calories in there and the baby's moving. Some use the little buzzer, the vibro acoustic stimulator. So it's up to you within your department. Some don't allow the fetal stimulation. They say it's falsely giving you false reassurance that everything's okay when it may not be. But make sure you decide within your lab what you're going to do, and make sure you're looking at where the position is at. And remember, if there's a fetal anomaly, specifically a head anomaly, then that baby may not be doing some of those components. And usually the fetal breathing is the first to go if the baby's running into trouble. But sometimes, we've had a couple that have had in utero strokes. So the things that you get the breathing, they're still doing the breathing, but they're not doing the movement and tone. So make sure that you do look at each component individually. And it was one of our nurses who picked that up because this baby just is not moving the way it used to. And then, if the baby's not doing everything it should, umbilical artery Doppler may give you some additional information. So just looking at what the umbilical artery SD ratio The normal placenta has low resistance to flow, so we should always see forward flow in diastole. So this is our typical thing that we want to see. And we look at the SD ratio, we look at the resistive index and the PI, the pulsatility index. So as long as we have good flow, that baby's doing pretty good. And there's ranges that will follow for the different gestational ages. The SD ratio will decrease with increasing gestational age. From 18 to 20 weeks, the 95th percentile is 7 to 7.9. At 21 weeks, 95th is at 6.7, and gradually decreases to 4. And then after 30 weeks, then it should be below 3. So again, it's important to know what range do I use for what gestational age. So if I get a cross-section, here's a vein with both arteries. If I'm seeing a cross-section of the cord, well, then I'm going to rotate my transducer 90 degrees so that I can get my angle of inclination as close to 0 as possible and put it right on that artery. And remember, there are 2 arteries, so you can have one artery that physically is a little bit smaller in size, so the SD ratio may be higher. So make sure you sample both arteries in that case. Make sure you look at both of them because it's an average of how much blood is coming back. This one's abnormal. Look, we should have high flow in diastole. Look, this is umbilical vein here, umbilical artery there. We've got no flow in diastole. Again, this one, IUGR, this is the only pocket of fluid we saw was that one right there. The rest was all cord. So again, absent and diastolic flow. This is a baby that's in trouble. This one's actually reverse and diastolic flow. This one went from the ultrasound room up to labor and delivery. And that baby was growth delayed and did have oligohydramnios. So the reason we do these, once a week or sometimes twice a week is depending upon maternal complications, their clinical history. What are their clinical symptoms? What's going on? So remember, both the BBP and the fetal Dopplers are valuable tools for the evaluation of fetal health. You must know the grading criteria for each of the components. Everyone within the department or your lab must follow the same guidelines. If the fetal score is 8 out of 8, you can be done in 5-10 minutes if they're doing everything. But if you don't see everything, you have to give them the full 30 minutes. And just for legality's sake, go back to your first image and see what time you started, because that's what they're going to look at. If you're a minute or two short, they're going to say you didn't do the full 30 minutes. So make sure you go back to your first. If they're not doing it, go back and look. When did you take that first image? Because it's all about documentation there. All right, multiple gestations. So AIUM guidelines for multiple gestations. Multiple gestations require documentation of additional information. We need to know the chronicity, the amnionicity, comparison of the fetal sizes to each other, the estimate of the fetal volume, amniotic fluid volume in each side of the membrane, and then the genitalia. So the best time to evaluate for chronicity is in the first trimester. I love it when we get referrals at 36 weeks to evaluate twins to determine chronicity. 36 weeks, come on. The best time to look is in the first trimester. You guys are going to see it before we ever see them. So you want to look at the number of yolk sacs because the yolk sacs parallels the number of amnions. Transvaginal is the best way to look because of the higher resolution. You physically can get closer to that gestational area so that you can assess how thick is that membrane, how many yolk sacs am I seeing. And it really helps to plan the whole rest of the pregnancy management and improve overall outcomes if we know the chronicity. In higher order of multiples, count the chorionic sacs, then the amniotic sacs, and then the embryos. So, example of this. So, triplet can be a trichorionic triamniotic. So, 3 placentas, 3 amnions. It can be dichorionic triamniotic. So, a singleton with a monochorionic pair. So, you got 2 placentas, but 3 amniotic sacs. Dichorionic diamniotic. So, you have a singleton with a mono-mono pair. And then monochorionic triamniotic. So you've got 1 placenta and 3 amniotic sacs, and this one's really rare. But that's what you're doing, is you're counting how many placentas do I have, and then how many amnions do I have? What do they share? I mean, we had spontaneous quads, and it was 2 sets of monochorionic twins. All of them boys. So what are some of the concerns that we see with multiple gestations? Well, growth restriction is more common in multiples. Discordant growth due to unequal placental sharing, where one baby just physically has more of the placenta nourishment than the other one does. Anomalies are 2 to 3 times more common in twins. Placenta previa and vasa previa, more common in twins and in multiples. More babies you have, it really increases your risk for this. And then the increase in maternal complications. I mean, there's only so much room at the end. The more babies you have in there, the greater and the earlier you're going to have complications. So the risk varies with chronicity and amnioticity. So multiple gestation imaging, we're going to go determine the chronicity, closely monitor for growth, look for signs of crowding, such as clubfoot. Sometimes you even get if they have decreased fluid, the little smushing of the face, abnormal posturing of the hands, all because of the crowding. You want to carefully monitor that amniotic fluid, your single deepest vertical pocket, and you have to make sure that you're perpendicular to the floor. You can't be coming to the side and angling in. You have to be straight up and down. Make sure that you're not measuring through the cord or fetal part. And again, that amniotic fluid discordance is the most important predictor of poor outcome in multiple gestations. So you really need to monitor the fluid and make sure you're getting the fluid for each of the individual fetuses. So your prognosis is related to chronicity, not zygosity. So how do we tell these twins? Well, dizygotic twins. You have 2 ova, 2 sperm, 2 zygotes, 2 yolk sacs, 2 placentas, 2 chorions. So going back to counting those yolk sacs early on, 2 amnions. You should see a thick intertwined membrane. You may see 2 separate placentas, but sometimes they're right next to each other, and it's hard to see that division. It'd be nice if all of them showed like this. I mean, this one's like, ooh, look at me. I mean, look how thick this dividing membrane is here. So this is also called the twin peak or lambda sign, and that's your most reliable indicator of dichorionic gestation. So it's dichorionic, 2 placentas, 2 amniotic sacs. So you have a wedge of chorionic tissue that extends into the base of the intertwined membrane. So that twin peak or lambda sign. And this membrane looks thicker because you've got 2 amnions, 2 chorions, where when it's 1 placenta, you just have the 2 amniotic membranes, so it's thin and wispy. The other way you can tell is if you have 1 boy and 1 girl. Now, they don't often line up like this, but I mean, when you see 1 boy, 1 girl, well, then you know that they're dichorionic. So both dizygotic and monozygotic twins can be dichorionic. So you can have monozygotic twins that can be dichorionic. They just split early. The earlier they split, the less they share, the less complications that they have. So both dizygotic and monozygotic can be dichorionic. Different genders are the most specific sign for the dizygotic twins. Now we'll go to the monozygotic twins. So all these other ones are going to be monozygotic twins. So you start with 1 ova, 1 sperm, the zygote cleaves to produce 2 embryos. So the first type that we can have is dichorionic diamnionic. So they split very early. Cleavage occurred early. Zygote divides within 3 days of conception. You have 2 implantations, 2 chorions, 2 amnions, and they're going to be the same as what you have with your dizygotic twins. You're going to have 2 placentas, a twin peak sign, a thick membranes because we have 4 layers, 2 yolk sacs. Now our next type of monozygotic twins is monochorionic diamniotic. So now we have 1 placental mass, and then we have 2 amnions. So cleavage occurred a little bit later, 4 to 8 days post-conception. You have 1 implantation, 1 shared placenta, 1 chorion, 2 amnions, 2 yolk sacs. So monochorionic twins have a 3 to 5 times higher risk of problems than dichorionic twins. So just being twins increases the risk. Well, now we're going to even make it higher because now they share a placenta. Almost all monochorionic placentas have intertwin vascular connections. Problem is they don't always share equally. So 80% of them, are going to do fine, not have any problem. There's that 15 to 20% of monochorionic twins that end up with problems. So with the ultrasound findings, single mass, placental mass again, same gender, because remember they're monozygotic, thin intertwin membrane, because it's just the 2 amnions, there's 1 chorion, higher incidence of eccentric, marginal, and velamentous cord inserts, just because they're a monochorionic diamniotic gestation. You can have discordant twin growth, resulting from the unequal placental sharing. You can have anomalies in one fetus that can cause a difference in growth. You can have twin-to-twin transfusion syndrome, is when you have an unequal sharing of the placenta because of the placental vascular anastomosis. You have asymmetrical fluid distribution and growth. You have your donor is going to be the donor twin would be the one that's pumping some of its blood over to the other baby. And so that baby is going to have oligohydramnios and growth delay. So the first thing we notice is the decreased fluid and then a small stomach, small bladder. The recipient, on the other hand, has more blood than it knows what to do with. So then it gets too much fluid, a big bladder, and a big stomach. And you get cardiac hypertrophy in the recipient twin because it's trying to accommodate all this and it's working, and then all of a sudden the hearts just can't work well anymore. You have a volume overload. So this is what I was talking about, making sure that you can identify those membranes. See, all this fluid, the first time this patient was scanned, there was normal fluid on both babies, and I'm like, there's no way. Put that color on there, this is the only fluid that child has. All of this is from the other baby. So the one baby's over sitting in one corner, barely moving, and the other one's like, whoo, I got the Olympic-sized pool, I'm moving everywhere. So and the one that's harder to scan is the one that's in the polyhydramnios because they're moving everywhere. You can't get them to hold still for any of your Dopplers. The little one who's sick is just kind of laying there so you can get everything because they're not moving. But really, if you don't have those little color filters, just go ahead and turn up your overall gain. It makes a difference. You really have to see where those membranes are. That was it. And the way to look is don't look around the head or the tummy trying to see where the membrane is. Look for the arms and the legs because that's what's moving. If the baby's moving at all, it's the arms and the legs. And that's where you see the membrane being distended as the baby's moving the arms and the legs. Look at this. They said this baby had normal fluid. This is that baby's membrane there, and it looks thicker. Do you know why it looks thicker? Because it's membrane on membrane. Its own membrane, this baby had no fluid around it. There's no fluid, so that baby's membrane's just kind of stuck together. It's the way it looks, it's called like a bell clacker appearance, where it's just kind of bopping around like this because it's membrane folded on itself. There we go. See it right here? This is cord here. All this other fluid is from this other baby. All right, so monochorionic diamniotic complications, some of the things that we can see is the discordant growth versus SIUGR. So selective IUGR. The difference between that is that the selective IUGR, they have normal bladders and stomach. So one's small, but they have normal fluid, normal bladder, normal stomach. So it may result of the unequal placental sharing, may be a result of anomalies in one baby, chronic forms of fetal-fetal transfusion, so like TAP syndrome. We'll talk about that in a minute. So TTTS, which is the one that most people know about, is twin-to-twin transfusion syndrome, versus TAPS, which is twin anemia polycythemia sequence. And there's that article if you guys want to look at it. But discordant growth, just by looking at this, look at this baby's tummy versus that one's. So just visually, as you're scanning through, you can see the difference. Again, look at that small tummy, that one. But it has a normal stomach, normal bladder. So twin-to-twin transfusion syndrome is characterized by twin oligohydramnios polyhydramnios sequence, or TOPS. That's what TTTS is. It's an asymmetric fluid distribution and growth, oligohydramnios in your donor twin, polyhydramnios in your recipient twin, and affects only about 9 to 10% of monochorionic twins because of this unbalanced intertwin blood transfusion. So it's the best known clinical syndrome with monochorionic twins. So again, look at, there's the smaller baby. Look at that fluid there. There's the bigger baby. There's the smaller baby. Again, that amniotic fluid is the first thing that lets us know these babies are at risk. Then your TAPS, or twin anemia polycythemia sequence, is characterized by a large intertwin hemoglobin difference, but it's a slow transfusion. It's just a large difference in their hemoglobin. They have normal amniotic fluid. I mean, their fluids are usually pretty similar. This occurs spontaneously in only about 5% of your monochorionic twins. And the reason there's a rise in this is because we're doing the laser treatment for TTTS, and what raises up to almost 13% after we do the laser. So we're having to follow these kids now, looking at the MCA, to make sure that they don't develop TAPS after TOPS. It was first described in 2007. So TAPS, few small anastomoses, the slow transfusion from the donor to the recipient. There's no hormonal imbalance. There's an absence of amniotic fluid discordance. The discordance is in the peak systolic velocity of the MCA Doppler. So your donor is going to increase MCA greater than 1.5 MOMs, suggestive of anemia, and the recipient has a decreased MCA of less than 0.8 MOMs, which is the suggestion of the polycythemia. So it's that difference that lets us know that these babies are at risk. So even after we've done the laser ablation, we still have to follow them to make sure that they don't develop TAPS. So 10 to 15% of the pregnancies of the monochorionic diamniotic twins develop TTTS. Some authors state up to 20%. One of the fetal surgeons I work with, Dr. Urano, says it's 20%. And I said, that's because of the population we see. Development of TTS is associated with significant morbidity, mortality. If it's untreated, perinatal death in about 90%. And that's why they started to do all these interventions. We used to do them where they used to do a big opening. I mean, we'd open up mom from the top of the uterus down and then try to get rid of some of these connections. Now everything's done with a little laparoscope. They come out and they've got 3 little Band-Aids and that's it. It's phenomenal the way it's changed. But neurological impairment, about 50% of your survivors if they didn't die in utero. The earlier the onset of TTTS, you know, by 16 to 18 weeks, the higher the mortality rate. So, and then one of the things that we do that's a little bit different than other places, and I've got this article listed here, is what's called the Solomon technique. So what they're doing is they go in there and they do the ablation, you know, the AVs and then the AAs and then the VAs, and then they connect them all together. Because they were finding if they just went in and did the big vessels that were on the surface, then the smaller ones that were underneath started to grow, and then you ended up with a repeat of the TTTS. So they're actually going in there and trying to make like an equator between them, and they're doing much better now. Okay, so the staging for TTTS is based on the ultrasound findings of the amniotic fluid, the biometry, the size of the bladder and the stomach, your Doppler evaluation, and then the cardiac evaluation. The treatment for TTS is the fetal laser ablation. Solomon technique is a little bit higher survival rate for both the twins and neonatal survival rate, and it reduces the risk of the recurrent TTTS or TAPS. So it's, you know, one of the things that they're looking at now. These are the different stagings that we see with twins. Stage 1 is oligohydramnios in the donor twin, polyhydramnios in the recipient. Stage 2 is absent bladder in the donor. Stage 3 is your abnormal Dopplers. Stage 4 is the hydrops, and then stage 5 is the death of one of the twins. There's different scoring systems out there. There's Cincinnati staging. They rely more heavily on the cardiac dysfunction in the recipient twin, and so they're acting earlier based on the cardiac findings. So this is the 3D showing how all this other stuff is all the other babies membranes. This is this baby's membranes just kind of together. This is after the surgery, because in the beginning we couldn't even see any fluid around this child. So after they've done the surgery, now, I mean, we follow them every day for the first couple days just to make sure that there's no rupture of the membrane and that the baby's reaccumulating the fluid and that it's starting to move that membrane away, and make sure the size of the bladder, the stomach, and the Dopplers. So pulsatile umbilical vein is one of the things we look at also. And we used to do it in the cord, and really what you should be doing is looking right at the umbilical insertion into the abdomen, right as it comes into the abdomen before it goes into the ductus. That's where you should be looking at your umbilical vein. Okay, monozygotic twins. So the last pair that we're going to look at is monochorionic, monoamniotic. So there's the one placenta, but now they share the same amniotic space also. So cleavage occurs after the amnion formation, so after 8 days post-conception. You have one implantation, one shared placenta, one chorion, one amnion, one yolk sac. Remember I told you to count those yolk sacs? It's going to help you decide what's going on. It's rare, and now, like with the monochorionic diamniotic, you have the abnormal cord insertions. Usually these cord insertions are very close to each other and usually pretty much in the center of the placenta. They may be a little eccentric, but they're usually not marginal or velamentous. The greatest risk these babies have is cord entanglement because they're in the same space. So ultrasound findings, no intertwin membranes. Make sure you're looking for that membrane very closely. Make sure you're not missing a monodi pair. No intertwin membrane. Cord entanglement is their highest complication, so look for the close insertion sites into the placenta. And then conjoined twins. If they divide really late, then they actually share body parts. So the placenta, look at how twisted this cord is. So their risk for the third trimester loss just because of the cord entanglement. And then the really late division of the mono twins is when they share. This one was actually referred for that they couldn't get a good BPD. And they were joined from the neck up. This is from the fetus.net. So the early on. So a lot of your conjoined twins end up with first trimester losses. This is a Omphalopagus. You can see where they're joined here at the abdomen. This is another pair that had one body, 2 arms, 2 legs, but then as the spine came up, the cervical spine divided into 2, and then the 2 heads. And this was the 3D of that. So looking at the spine, you see how it divides here. So be careful when you're looking at these babies. Make sure that they all have their own separate body parts. Okay, so we've been looking at things. Let's look at this video clip. Tell me, how many placentas do you see? Because we're talking about counting amnions, counting placentas. So this is your quiz. What we saw, oh, come on, you guys, you can do this, look. Well, there's other body parts down here. Okay, I'm gonna help you out. Here's one placenta. There's another placenta, there's another placenta. See, you had that Twin Peaks sign there? So there's 1, 2, 3. Okay, and we're looking, trying to look just for the membranes. So you had 2 posterior placentas. There's that lambda sign, and we had a placenta up here. So there's a head, there's a body, and then there's the one in the middle. Do you see that? So again, just taking time. You have to take time looking, but you're surveying through. So this is a trichorionic, triamniotic, triplet gestation. Look at the baby waving at you at the end. Like, okay. All right, and then just some website information for you, looking at the AIUM, ARDMS, SDMS. These are all good references for you guys. Just remember, I mean, when you go on to what is required for me to document and have these scans done in my office, go to AIUM.org. They've got them all listed out there. You can show it to your entire staff. These are the and they'll tell you, these are the minimum things. You can do more, but these are the minimum things we want you to do.